Blog Talk Radio.
Good evening. This is Marianne Russo. I'd like to acknowledge my co-hosts tonight that are over on the Twitter tweet chat, Mae Wilkinson and Chuck Wally. You can join them with the hashtag TCK and discuss the interview. I am honored tonight to have Dr. Duncan McKinley as my guest. He is a psychologist in Ontario. He himself was diagnosed with Tourette's syndrome at the age of 19, and as he's going to tell us, he knew that he had this secret by age 7. And, what he has done with his life and done for families and children and adults with Tourette's is just unbelievable. He is the author of Nix Your Tics, which is amazing, and he is the creator of the award-winning documentary, Life's a Twitch. He also, as is featured this month in the Canadian Journal of Psychiatry, they're featuring the first ever Canadian guidelines for treatment of tic disorders. And his non-pharmacological treatment for tics, outlined in Nix Your Tics, received a strong level 1, and it is now considered one of the first-line treatments. So I'm honored. Dr. McKinley, thank you for joining me.
Oh, I'm pleased to be on. I'm very impressed with what it is that you and your organization do for families and parents out there, and I'm impressed with all the folks who've been interviewed before me. So I'm in good company.
Yes, you certainly are. We're really just so fortunate that we've had so many people on to help these families because we're struggling. These are very complicated disorders that we're dealing with. And tonight we're going to be speaking about Tourette's, but not just Tourette's because, Tourette's is just a big ball of wax. There's a lot of comorbidity or, maybe it's a spectrum. We're going to discuss that too. But let's start at the beginning with the onset of tics. You yourself have Tourette's syndrome, and you knew it from a very young age. So why don't we first go over tell us a little bit about yourself, and then let's talk about, I know all our kids are very unique, and there's no one-size-fits-all, but, what is the typical age of onset, and what are some signs parents would look for?
Sure. You're absolutely right in terms of all the comorbidity and the big ball of stuff that those few and far between of us that work in Tourette's clinics around the country are in secret is that even though we call ourselves Tourette's clinics, we're really in practice everything that goes along with Tourette's clinics. That whether it's a frazzled parent or a burnt-out teacher or what have you, usually when people are coming in to see us, they're saying, "My God, I wish he would just tick." It's all the
right.
all the blow-ups, all the sensory sensitivities, all the perseverations, all the impulsivity, all the inattention that's causing more of the issues. But in terms of your question, when do tics typically start? There have been some very big studies looking into normal epidemiological factors internationally. In fact, there's a database called the TIC database. It stands for the Tourette's Syndrome International Consortium of Studies. And last I checked, I believe there's about 26 countries that are contributing data into that massive database. And what they found is that it's around the age of 6 on average.
Okay.
Tics first start. Now, the comorbid issues could be occurring earlier. ADHD, certainly, there can be signs of that a lot earlier. But on average, between 5 and 6.
I'm surprised. I thought it was actually a little bit older because my daughter was about 5. And hers, I know that we've discussed this before about, whether it's pandas or not pandas, but hers did start after a strep infection that didn't go away after 3 rounds of antibiotics. It was very, very sudden onset. So the typical age then is much younger than I thought. I thought it was more like 9 to 13. Wow, that's young.
Well, what's been found is that the progression is a bit bimodal. There's bimodal peaks that people first start ticking, people first notice the surge around 5 or 6, and then around that time that you're discussing, around the 10 and a half, 11, is another peak where, in fact, studies that look retroactively at sort of quote-unquote worst ever tick period tends to be around 10 and a half. And so I think certainly things are more obvious then. Maybe things are harder for kids to hide or suppress by that age so they get noticed. Or the ticks are a little bit more at that point maybe obvious as ticks. That when ticks first start, they start typically in the face, and they're usually pretty normal, subtle motor movements that are just coming out a little bit more than they should. Things like eye blinking and sniffing, and so oftentimes, even though those are bona fide ticks, those are common ticks, and they're starting much earlier than the 10 and a half. You get families and doctors running through the gamut of other possibilities first, thinking, well, maybe my child has dry eyes. Maybe my child needs to see an ear, nose, and throat specialist. They're clearing the throat all the time. And so maybe as ticks progress, become a little bit more complex, people start to catch on.
Right. You know, it was back then, I mean, the Internet was fairly new, and I remember just going online one night and typing in throat clearing and lining things up, and boom, it just came up. You know, but when my daughter first started having all of these symptoms, you know, I didn't know what to do, and I couldn't understand what she was going through. She was so young. So I went to local support groups.
Right.
They allowed me to go in and speak to kids and teens that had Tourette's. And one thing they all relayed to me, and I mean universally, they all said the same thing, that they had a feeling of inner restlessness before the onset of tics ever began, and that restlessness remains with them. And one boy explained it to me as an itch that he can't scratch. Right. And that it makes it difficult to learn and focus and even make friends. So what can you tell us as parents or educators, because we get a lot of teachers that listen to the show, about this inner restlessness so we can understand these kids a little better?
Sure, and that's a great question. There's a lot I can say about that. The technical term for it is premonitory urge, but much more commonly you do get articulate young lads like the one you mentioned describing as like an itch, or other kids might call it like a tingle or a pressure, or even a sensation of heat building up. Basically, this premonitory urge element, it's something that a lot of people don't know about tics, and it's actually a crucial piece on a number of levels to understand about tics. From a diagnostic standpoint, first of all, there's a lot of movement disorders out there, of course, but having the movement preceded by this premonitory urge is unique to tics. And so that's why, for example, even though I'm a psychologist, I'm not a quote-unquote real doctor, I'm not a physician, I didn't go through medical school, I can still diagnose Tourette syndrome competently, because there are certain questions that, even though I'm not trained in all these other movement disorders like a neurologist would be, there's certain questions that you can ask that, for example, once you know that there is this premonitory urge, this itch component coming first, you can immediately eliminate all sorts of other neurological possibilities right off the bat. So, I mean, it's important diagnostically, but it's also important in terms of, like you mentioned, teachers listening, that I know a common thing, and certainly I spend a lot of my time when I'm doing presenting helping to educate, because I meet a lot of really well-intentioned people where their well-intentioned ideas are blowing up in their well-intentioned faces simply because they're underinformed. They haven't been given the information, the tools they need to help these kids and to get the classroom rolling smoothly, or the family functioning, or what have you. And so helping teachers to understand that actually the tic isn't the involuntary part, it's the itch that's the involuntary part, really helps to explain some different things that they often see in the classroom. So, for example, I'll often hear from, well, not just, I also want to pick on teachers, I'll hear from parents too, well, I don't know if that's a tic. I don't really buy that, Johnny's got Tourette's, because when I tell him to stop, he can. And if you hear that this is a neurological disorder and that they can't help it and that it's in the brain and blah, 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 and yet they're stopping when you give them holy hell about it, well, that doesn't seem very neurological to me until you understand that really the reason these kids are ticking, to follow the analogy through, if the premonitory urge is the itch, the tick is the scratch.
Right.
And so if you think of, I'll invite your audience members to think about if they're covered with mosquito bites or if they're covered with poison ivy or if they have the chicken pox, just the impact that, not wanting to scratch the chicken pox because you'll leave a scar, what have you, the impact of, say, sitting through school all day, being covered with all of these itches and sensations, your skin practically writhing under your clothes, screaming at you for attention. And but you can't itch it. You don't want to itch it. You'll get in trouble if you itch it. It helps to explain a lot of what you see with these kids. It helps to explain why they're Jekyll at 9 in the morning and a frothing, seething, non-compliant Hyde by 2 in the afternoon, because they're exhausted from holding
Absolutely.
in, all these itches. It also helps.
They walk in the door after school and there's just an explosion.
Well, that
of ticks from suppressing it. It's horrible for these kids.
There's 8 hours of not scratching the itch, so to speak, and it helps people to understand too that it's not only typical, but it's expected that a person with Tourette syndrome can have some loose, slippery control over that scratch. But so for example, if I went to school every day and I went to my math class, and whenever I ticked, my math teacher would point at me and ridicule me and send me out in the hallway, and I'd get laughed at. And then I go off to gym, and in gym, every time I tick, the gym teacher comes over and says, well, I know you have Tourette's, that looks like it's painful. Do you want a neck massage? It's not going to take I didn't fall off the apple cart yesterday. It's not going to take very long until I'm never ticking in math class, and I'm ticking all the time in gym class. And of course, the irony there is that from an old school perspective, people would think, well, that math teacher's doing something right because she got rid of the ticks, and that gym teacher must be doing something wrong because that kid's ticking all over the place in the gym class. And so we would be, first of all, assuming that this kid must just be playing the teachers. It must just be a behavioral thing because he can hold it in one place and not in another. But also, we'd probably be getting after that gym teacher for being a crappy teacher because apparently he can't keep this child under control the way the wonderful math teacher can. And so it really leads to a whole lot of interesting discussions. Even things like when teachers will say, well, I'll yell at him, I'll give him the evil eye to get him to stop ticking, and he'll stop ticking, but then I'll turn back to the board and he'll do it again. And I'll turn around quick and he'll stop and he'll just kind of, smile at me. And so teachers, understandably then, who have been, underinformed, will get really angry thinking this kid's really screwing with me. He's just, pushing the envelope. But of course, it's not unlike if you've got this itch that you just absolutely have to scratch, and mom's telling you don't scratch it, it'll spread the poison ivy, and she leaves the room. Yeah, you dig in when no one's looking. If she comes back in, oh, sorry.
Right. And it's so heartbreaking. And I think that we've made great strides as parents advocating for these kids. But it is so hard because it's not just as simple as we're going to talk about of the simple tics or the complex tics. It is an inner restlessness. It is a sensation in the body that is very difficult to deal with. And a lot of this is a genetic disorder. Is that correct?
Yeah.
Okay, so it's a genetic disorder. So I think a lot of confusion comes into play. Oftentimes parents, many parents, say to me that their child went on a stimulant for behaviors, for
right.
ADHD or whatever, and then they developed the tics. I think it's important that parents understand that the stimulant did not cause the tics. Now, and what I'd like for you to explain is, how the gene is expressed or turned on, or is it because it's changing the neurotransmitters, the norepinephrine, the dopamine? Why does that happen to some children that go on the stimulants, is my first question. And then the next follow-up question would be, does it abate when the stimulant is removed, or is it best to maybe add something else or do a different treatment if the stimulant is helping in other areas?
Sure. Oh, you've got excellent questions.
Thank you.
A few things I can say to that. One is that, stimulant medications do impact dopamine levels, and dopamine or sensitivity to dopamine is what's involved with Tourette syndrome. Now, we're talking about before the program started, even how wonderful internet and all these things that blog radios and such that it allows. Of course, then there's the other side of the tracks of the internet, where
it's a double-edged sword.
Clinicians like myself have been trying to expunge this myth that that stimulant medications cause Tourette's or increase tics in all kids with Tourette's for ages and ages. It was a really bad study that was done in the early 80s that has been thoroughly debunked, and yet, of course, the myth persists. I guess to more directly answer your question, and I'll just try to summarize a lot of research here. Basically, what we found is that if you're going to have Tourette's anyway, if you've got those genes, if the Tourette's is on its way anyway, a stimulant medication will serve as a catalyst. It will speed up the introduction of those tics. When you were talking earlier about there being a variance in when people first show tics, that could be one factor involved. That maybe you get tics 6 months earlier than the average because your ADHD came out first and someone thought to put you on a stimulant medication. Now, that being said, there's also now, and again, this has been replicated again. There's a global consensus working group in the ADHD area that has firmly supported this stance. Stimulants don't automatically equal tics or more tics. In fact, what studies have shown is that for every child, when they're put on stimulant medication, their tics get worse. There's another child that when they're put on stimulant medication, the tics get better. And for another child, again, where the tics aren't influenced at all. In fact, actually, one thing even I mentioned in my book is that if you've got ADHD, I highly recommend that a person optimize their treatment of ADHD with stimulant medication before they start using the treatment in mix, because they're going to be a lot more successful at
Absolutely. I just had Dr. Charles Parker when we were debunking the New York Times op-ed. And, basically that's what we were saying, that a lot of these kids need to be on the stimulants so that they are approachable for other therapies.
Exactly. In fact, when you talk about the big ball of wax or what have you, all these different things, what do you deal with first? Pretty much always. I mean, very rarely there'd be an exception, but pretty much always it's the ADHD first, because you're going to get more traction with everything else once they're a little less impulsive, once they can attend a little better. Now,
and that's the next group of questions I was going to go into. I don't want to interrupt you, but you can finish your thought.
I just wanted to finish answering that question because you asked if the tics abate after stopping the stimulant, and it depends. As I say, if it's just a side effect, if you don't have Tourette's, if you're just on the wrong stimulant, or like for example, the dextroamphetamine mixtures seem to be
or the wrong dose, right?
Yeah, the wrong dose, or dextroamphetamine mixture seems to cause tics more than the methamphetamine. If you're on the wrong dose or what have you, and the tics start coming out, and then you stop the medication, then the tics go away. However, as I say, if you were going to have Tourette's anyway, and all the stimulant did was catalyze the appearance of them, that's when going off the stimulant medication isn't going to make the tics go away, because the tics weren't caused by the stimulant in the first place. They just sped up their arrival.
Right. That's what I really wanted you to just get out there to the parents, because I think that is really a misconception that parents have to understand that it doesn't cause Tourette's. The Tourette's is there. Just briefly before we go into the ball of wax, because we are going to go into depth a little bit about comorbidity, but I did want to talk about the different types of tics, because there are simple tics, there are complex tics, there's echolalia, and the myth of this being the cursing disease. And coprolalia is actually quite rare in in Tourette's. So can you just go briefly through the different types of tics and explain, I don't even know how this whole thing that, it's the cursing disease, because it is so rare and parents just fear it.
Right. Actually, the way that got started was the original paper written back in 1885 by George Gilles de la Tourette. The patient that he was chronicling, the Marquis de Dampierre, had that particular symptom. And so in his initial paper, he postulated that perhaps one of the dimensions of this disorder was that tic. And so that, again, has been something it's not part of the diagnostic criteria. Less than 10% of people have it. Even rarer in children, even rarer again in mild cases. Usually it's the comorbidity that brings it out. But you're right. It's very media friendly, and it's well for comedians to go to. So it's I think that probably explains the continuation of that belief more than anything. It's titillating. But you mentioned that there's simple and complex tics. You're absolutely right. And the simple tics are things like sniffing and eye blinking or a simple throat clear, the things that can be misunderstood as other perhaps medical issues. The complex tics, you mentioned a couple, the coprolalia and the echolalia. Basically, just to give a quick Latin 101, the lalia means speech, and praxia means movement. And so echolalia is a speech tic. It's when you repeat back what other people say. Palalia is when you repeat back your own words like that. And of course, coprolalia is the saying inappropriate things. And actually, people think it's all about swearing. It's not even that. Coprolalia is just saying inappropriate things. If I walk into a bank and see someone of a different ethnicity and I blurt out a racial slur, that's coprolalia too. And then the flip side, there's not only echolalia, palalalia, and coprolalia, there's also then the praxias. Echopraxia, where you imitate the movements of someone else. Palapraxia, where you do your own movement over and over again. Or copopraxia, where you do something inappropriate, like, say, shooting someone the finger.
Right. But getting back to the simple tic, my daughter, after the throat clearing and everything, she went into the blinking. And I was very fortunate. I got in touch with, I don't know if you know Bonnie Grimaldi. Her son had Tourette syndrome plus, as they call it when there's the comorbidity. And she had developed a vitamin regimen.
Oh, yeah.
And she told me one day, she's fantastic. One day she told me, have you tried a little bit of thiamine? Well, I mean, it was a fluke, but it happened several times. As soon as she would get the blinking tic, I gave her a little bit of thiamine, and within 2 days it was gone. It was just amazing.
Well, I just read a quote the other day on Google that said, if a placebo effect creates real change, is it any less real than an actual real treatment?
Absolutely. Who cares? Right, if it's benign, who cares?
Yeah.
Tourette syndrome is a neurobiological disorder, and it's often comorbid with mental illnesses such as OCD, ADHD, bipolar, Asperger's. Many people refer to it as Tourette's plus.
Yep.
So one of my first questions is, if this is a neurological disorder, why is the criteria for it in the DSM?
Okay. Yeah, that's a good question, because you're right. Where a lot of people try to figure out, is this neurological? Is it psychological? Is it psychiatric? And really, it's a bit of a semantics game. That, I mean,
right.
We are neurological beings. Everything is neurological. I mean, ADHD is neurological too. OCD is neurological too. Me talking to you on a blog radio is a neurological act. I mean, we're neurological beings. And so I think a better way of understanding it, the way I often explain it to people, is rather than looking at it as an either-or, is it neurological or psychological or sociological or psychiatric, think of all those different terms as levels of explanation. Like if I go to the edge of a lake, I can analyze each grain of sand individually and be interested in how all those grains of sand are interacting, and that would probably be a neurological perspective. I could also just look at the entire beach as a whole and describe sort of how it how it makes me feel. Maybe that's what we would call the psychological level.
Right.
I could watch people interacting on the beach and how they interact differently on the beach rather than on the highway, and make some sociological comments. So it's really it's all the same thing. It's just how fine-grained are you getting in the analysis.
Right. And, to me, it's very similar to, like, autism, that they feel that it's not a mental illness. To me, and this is my very personal opinion, with my daughter with the OCD, and, her tics are gone now. But, it really doesn't matter to me. It's like you said, it's just a big ball of wax. But one of the things that I think is different about Tourette's comorbidity with these other disorders is that for some reason, as like with my daughter, the other disorders present differently. So I wanted to go through that a little bit. Like, we'll start with OCD. My daughter has Tourettic OCD, which comes from the expression of the Tourette's gene. And it's different than the classic OCD. There isn't the rituals and compulsions. It's evening up. It's more panic and fear. So, how does Tourette syndrome affect OCD? It's probably the most comorbid, wouldn't you say, of the disorders that goes with Tourette's. And in disorders like ADHD, bipolar, or Asperger's, do they present differently if it's based on, if it's comorbid with Tourette's? Sure.
Now, ADHD, which is probably the most common comorbid, it's when ADHD and Tourette's are comorbid, it's just ADHD and tics. I mean, it doesn't really impact the expression of ADHD. But you're absolutely right about the OCD. That, as you mentioned, there's a lot more things like evening up involved with it. Now, you'd mentioned that she has evening up instead of rituals and compulsions. I'm just going to reframe that a little bit. It's not an either-or with rituals or compulsions. Everyone with OCD has rituals and compulsions. It's more about which subtype of rituals and compulsions you have. And so the most common type of OCD that people have ever heard of is where the rituals and compulsions are around contamination and cleaning germs and that sort of thing. Probably the most common subtype in OCD comorbid with Tourette's is what we call, quote-unquote, just right OCD. And the compulsions there are things like evening up, ordering things, making things symmetrical, trying to make things, quote-unquote, perfect. The other subtype, actually, that's quite common in OCD comorbid with Tourette's is what we call bad thoughts OCD. And this is really, it tends to be a little bit more under the radar because, again, kids with this particular nasty type of OCD, they didn't fall off the apple cart yesterday. They realize all these horrendous, horrific thoughts that are popping into their head around aggression or sex or religion. They know these are horrible thoughts, and they're petrified that these thoughts mean that they're a bad person or that other people are going to think they're a bad person. So they really, really try to keep them under wraps. The compulsions that you tend to see with those kids is just asking the same question over and over and over and over again, this constant need for reassurance. Do you love me? Are you mad at me? Is Mom okay? Do you think I'm going to go to hell? Do you think God hates me? Am I doing this right? Did I hurt my sister? Are you sure you're not upset? And that ritual or compulsion is often the only tell that these kids have 24/7, just horrible guilt-inducing medley of bad thoughts in their head that they are trying to make go away.
And it's so hard for the parents because, you want to give them relief, but you don't want to overly participate, and it's so difficult. It's such a fine line. One thing I found interesting that I was told, because this is my other daughter, this isn't the one that had the Tourette's, is that girls can actually have Tourettic OCD and not have any tics, where boys, he had explained to me, would more than likely have both tics and the OCD.
Well, if a person doesn't have tics, then they don't have Tourette's, because that's really all that diagnosis is. But let me clarify, because I think I know where you're going with this. The four different subtypes of OCD, we've mentioned three. There's the contamination one, there's the just right one, there's the bad thoughts one, and then there's, of course, the hoarding one as well.
Yeah.
Those four subtypes can occur in anyone. Yes, the just right OCD and the bad thoughts OCD is much more common when there's comorbid Tourette's. But yeah, you can be a young girl with OCD and have one of those types that commonly co-occurs with Tourette's, but not have Tourette's. So in terms of boys versus girls, when there's both Tourette's and OCD, what the research shows is that boys tend to start showing their OCD very early. So there'll be a young boy who will be showing his Tourette's and OCD. And then as they're getting into the teen years, it's more often the girls that you'll see that will have both the Tourette's and the OCD. So by the time they're adults, it evens out. It's just as likely in men and women. But when it first appears, it is a little different depending on which sex you are.
Right. And I think for parents that have children that have Asperger's and Tourette's, it's difficult also because there's always the confusion, especially, you've never dealt with this before, of what's a stim and what's a tic, and, what's sensory, what's not sensory. It can be very confusing.
Yeah.
And, the rages, and I'm not saying all children with Tourette's rage. I'm not saying that. But a lot of kids do. And what do you account for that? Is there usually the comorbidity with the ADHD or bipolar, or is it just the frustration of the restlessness?
Well, I think a bit of both. I think you've nailed it with both your suggestions. That, there's the rage is more common with the comorbidities, yes, and when you introduce in the OCD, the ADHD, these other conditions, it's very frustrating because now you're not just dealing with dysregulation of your movements of your body, but you're dealing with dysregulation of your thoughts, of your emotions, potentially, of your attention, of your impulses, and of course all the the societal response to that dysregulation, which just stresses you out more. And so, I often talk about, people use the phrase low frustration tolerance often to describe these kids. And I often turn around and say, no, that's actually misleading and a bit minimizing. These kids don't have low frustration tolerance. What they have is more frustration to tolerate. That everyone sort of has a breaking point, and for most people, they're sort of, their beaker's empty enough inside, so to speak, that they can deal with a whole lot of crap on the outside before they reach that breaking point. But if you're trying to self-manage all of these different symptoms piled on top of one another, your beaker's already pretty full as soon as you wake up in the morning, and it doesn't take much.
Right. And, I would imagine that there's physical pain. Are these tics like muscle spasms? Because it's like I don't have tics, so it's hard for me to understand that feeling. Is it like a muscle spasm? Is it physical pain? And how do you deal with the pain on top of everything else?
Well, certainly that can be another thing that leads to the frustration. No, to go back to that itch-scratch analogy I gave earlier, it's very much like scratch and mosquito bite. So it's what doctors call an involuntary movement. So it's not voluntary. It's not you wake up in the morning and go, hey, I think it'd be a great idea to blink my eyes excessively all day. But it's not completely involuntary either. It's something, it's it's a forced choice, I suppose. The same way a really pernicious itch on your arm is a forced choice. I mean, and this is another place where there can be misperceptions that if a kid does a tick and a parent says, "Did you do that on purpose?" Odds are the kid's going to say yes, because if you have a mosquito bite on your arm and you go to scratch it, and someone says, "Did you do that on purpose?" Well, yeah, I did. There's a little bit more to it than that. It's you know, I itched it because I was trying to solve a problem. I was trying to solve this inner you know, tension or restlessness. But no, it's not any kind of involuntary spasm or seizure. But
okay.
You know, there are times that scratching the itch doesn't. It involves pain, which is, yeah, when it's really difficult. That what I need to do to get rid of the itch is something that's going to hurt me.
Oh, okay, I get it. Now, this is supposedly, from what I've heard, an anxiety-driven disorder. Now, I don't know if that's true or not. But if it is the case, then how does anxiety affect tics, and why would anti-anxiety medications not be a first line instead of the neuroleptics? You know, not that either one of them has no, you know, I think that the side effects would probably be less.
Well, OCD is an anxiety disorder. The itch scratch there is a cognitive itch, a worry, an anxiety that then the compulsion scratches. So Tourette's and OCD have that itch scratch cycle in common, but Tourette's isn't an anxiety disorder. It's more of a, well, as we've been saying, an itch sensation, more of a motoric urge that needs to be satiated. So in the case of OCD, you're absolutely right. I mean, the medications that are used are anti-anxiety medications, things like the SSRI medications, Zoloft and things like that. Yep.
So, you know, a lot of parents are confused because they'll say, well, I don't have tics. You know, my husband doesn't really have tics. You know, he has a little fidget with his finger. But they have a child that has, you know, full-blown Tourette's. So, you know, how do you explain that if parents say, well, we don't have Tourette's?
That's a good question. I mean, the same is true in my family. There's no one else in my immediate family that has tics. Think of it as being like genetic Lego. That, you know, at one time, as most things are in mental health at one time, you know, it was all mom's fault. That, you know, there was one gene, it was a dominant trait, and mom carried the gene. So, you know, thanks a lot, mom. But that's been debunked. We know now it's a lot more complicated than that. And the most current theories that fit the available facts the best at this point is that there are a multitude of genes involved. Some people have suggested as many as 80 genes may be involved in these disorders of dysregulation. And so let me just make some numbers up. Let's say you need to have 7 of these genes to have Tourette's. But if you've got if you've got 3 of these genes, you're just going to be a carrier. You're going to have the genes, but you're not going to show anything. And if you have 4 of these genes, that's maybe enough to show some OCD tendencies, but not enough to show Tourette's. Well, then you can have, you know, mom, who on the surface seems completely neurotypical, but she's a carrier, and she hooks up with dad, who's maybe got some anxiety, a bit of OCD. They get busy. They share their genes. 4 plus 3 is 7, and out pops their Tourettic child.
Right. You know, one of the things that we're getting a lot of questions. One question in particular that I want to ask you on the chat. Parents are asking how they tell the difference between stimming and a tic.
That's a very good question. There's a lot of physicians that aren't quite sure about stereotypies versus tics. I can give you a few hints, I suppose. For one thing, the stereotypies tend to be a little bit more complex movements. Things like, you know, clapping hands together, which involves a lot of muscle groups, and it's in the extremities. So the self-stimming seems to be a little bit more complex often than tics. Self-stimming seems to occur more just when a person's excited. whereas ticks, of course, will increase with stress, including excitement, but they're kind of, in one way or another, always there. Ticks tend to change more over time. That you have one for a while and then another one comes. Whereas self-stimming behaviors tend to be a little bit more static. Whatever your choice of self-stim behavior, choice being in quotes, of course, it tends to be a little bit more constant.
Right. That's great. That's what they're asking us. Nix your ticks.
Yep.
I have to say, I don't have the book here right now because I gave my copy away, who gave it to somebody else, and everyone just loves it. It's worth passing around. In this book, you really have, it just covers everything. It's a fantastic book. And you also write about the personal choice of medicating. And you say that really it's a choice of either suppression or expression. And it is medicating any child or adult is a very personal decision. And, the newer neuroleptics have fewer side effects than the older drugs. But you still have to weigh the risk, benefit. And, I wanted you to talk about, I mentioned earlier when we started that, they just have found that what you're teaching parents in Nix Your Ticks is what they're finding is the first-line treatment. So can you, I want to make sure we get into this because we've already been almost 45 minutes into the interview.
Oh, wow.
Tell us about Nix Your Ticks. I like it, too.
We'll get on.
Tell us about Nix Your Ticks because really, parents need this information. And I also want you to talk about, because medication is, some people need medication. So talk about that. And then I do want to mention, before I forget, that we discussed last time you were on about the medication holidays. And a lot of parents are very anxious. I'm one of them, who think maybe it's a great idea to take a break. In the old days, I've learned my lessons. And why that's not a good idea. So tell us about Nix Your Ticks. Take your time because it's worth it. And then tell us about giving holidays for medications.
Sure. So in terms of in Nix Your Ticks, the treatment in there, way back in the day, actually I think the first paper written about it was the year I was born, 1973. It was called, or at least a component of it was called habit reversal training. And habit reversal training worked really well for tics, but it wasn't studied a whole lot. Psychology studies generally aren't given as much funding or attention as medication trials, frankly, because there's not as much money to be made from them. And so this habit reversal training was kicking around for quite a while before it really got seriously looked at. And there were other more behavioral, psychological types of things like relaxation training or self-monitoring, social support, all sorts of different things that were being tossed around as possible treatments or ideas that could help non-pharmacologically with tics. And so finally, and I give the Tourette Syndrome Association in the States full points for this, they don't care whether, they make lots of money from a treatment or not. They just want to help their constituency. They just want to know what works. And so they partially funded, along with the National Institute for Mental Health, a $6 million study, multi-year, multi-trial. It really was a big flagship study. Data was being gathered for about 6 years down in the States to really comprehensively look at all the different behavioral ideas, not just habit reversal training, but the other stuff too, relaxation training, such, and what works, what doesn't. And basically, long story short, what they found, the things that work, they've piled them together into what they call CBIT, the Comprehensive Behavioral Intervention for Tics. And basically, it's a compilation of all the things that behaviorally that work. And by behaviorally, I know there's lots of connotation of that term. Basically, what I mean by behavioral treatment is it's something you do rather than something you take. That's all I mean by it. So no implication to bad parenting or bad choices or anything like that. So basically, all of these good behavioral techniques have been piled together and found to be, as you mentioned, is coming out in our guideline this month, the most efficacious treatment out there, when even compared to medication, with lots fewer side effects, no side effects, and a treatment that you can tailor a lot more, where you can actually choose the ticks that you want to get rid of and target them to decrease them. And it also lasts longer, too. One of the problems with medication treatments is that the relapse is high. As soon as pills don't have skills. As soon as you're off the medication, you're off the treatment. But
is this like CBT at all, like cognitive behavioral therapy, in a way? Or is it very different?
It's more emphasis on the B in CBT. But, yeah, there are a lot.
I got you.
That the type of cognitive behavioral treatment that's used in OCD, it's the most effective treatment we have for OCD, is called exposure and response prevention. And there are a lot of parallels between what I talk about in NICS, this new evidence-based treatment for tics, and exposure and response prevention. In a way, you could think about CBIT or tic management as being like an ERP for tics. It's a little bit more of a motoric ERP in a way.
Okay. You also write about, because education is so hard with these special needs kids, and with kids with Tourette's, you talk about, I call it outing the child. And you wrote about how this was your big secret, and it was probably the worst kept secret in the world because, kids see the differences anyway. So, I wanted to talk about, how the importance of really outing your child's Tourette's to the school, to, maybe other parents, with respect and compassion.
Right. And, there's some different tips I can give for that. I mean, you're right that it's one of these places where the road to hell is paved in good intentions, that, you don't want to bring more attention on the child, but ironically you tend to bring more attention on the child by not talking about it. That kids, once they get what's going on, they very quickly move on. Whereas if they don't know what that tic is, they're going to react every time. They're going to bring even more attention to the tics. They're going to get sensitized to the tics rather than used to the tics. If they think the kid's doing it just to get attention or because he's weird, then, they're going to get even madder at him. They're going to ostracize him more. They're going to, ultimately, in a backwards sort of way, talking about your tics is the best way of putting your tics out of the picture. And so in terms of some different hints, when I advise people to do in-services or when I do them myself, first of all, I tell them use really developmentally appropriate language and metaphors. That I do talk about itches and scratches, or with OCD, I talk about it as being like an internet pop-up ad in your head that won't leave you alone. Like,
well, that's good.
As you use big, complicated language that might be technically correct, people don't know what that means. It can cause more stigma and more distance. Whereas if you say to a bunch of kids, have you ever had a mosquito bite that, just drove you nuts and you wish you could stop scratching it, but you can't, and you're getting in trouble for scratching it, but you can't stop, all the kids can relate to that. And so you can then, through a universally relatable experience, help them to understand that that's what Johnny's going through. And he shakes his head. That's him scratching his itch.
Right.
I also think it's important to do it when they're young. Don't wait till there's a big problem, because by the time I was 7 by the time I started figuring out, hey, I seem to be different from everyone else, and I don't know what it is, but it seems to be bad. I mean, the damage was already getting pretty significant at that point, because it was doing a lot of damage to my self-esteem, and that takes years and years and years to undo, if ever. So starting off...
Yeah, you're absolutely right. My daughter was 4. She was in preschool, 3 or 4. And she came home one day and said, Mommy, why am I different than the other kids? And my husband and I looked at each other like, what is she talking about? And she told me she knew.
Yeah, good for her.
These kids know. These kids just
And they may not have the language for it, which we can provide, but they know something's up. So, yeah, start when they're young. Tell parents, do it at the beginning of the year. Again, don't wait till there's a problem. Once you're in reactive mode, no one's listening. Do it at the beginning of every year, or, whenever you're switching schools, whenever you're going into a different class. Invite as many, staff as possible. Remember, my preference is to do whole school assemblies, because it's not just the kids in the classroom, it's the kids at recess, and it's the teachers that are monitoring lunch, it's the cafeteria staff, it's the bus driver.
I spoke at the superintendent's conference when my daughter was first diagnosed. I went in to speak with them. They invited me to speak to the entire staff, and it's important because, like you said, the woman on the playground needs to understand why my daughter's doing this.
Yep.
But one thing, and I just want to say, Nix Your Ticks is an absolute must, and I am not just saying that. This book is an absolute must for any parent who has a child with tics. And you can go to lifesatwitch.com and you can order it right from there. But a couple of things in your articles that really struck me was that you say that, people often think that, people with Tourette's choose to be loners because they're embarrassed of their tics. But in fact, it's because stimulation worsens the tics and the disorder.
Right.
And you use an analogy to the volume on a stereo.
Sure.
So if you can just explain that and teach us, how do we find our child's volume?
Sure. No, it's a good question to bring up because, Tourette's aside, one unfortunate thing I think about North American culture is that we seem to treat introversion as being a disorder. And, to each their own. It's interesting, the clinical work I do, we often... one of the first things we're doing in the admission appointment is trying to figure out really what's this child's definition of success. Because there's not, what's going to make Johnny happy and productive and feel quote-unquote normal is not going to be the same criteria that Susie's going to use. And so for some people, they like their stereo loud. They don't mind that they're different. They're going to be more disordered if people start telling them there's something wrong with the way they are. And so for those sorts of kids, it's really more, it's less about trying to change them or to mute them, and it's more about just giving them some driver training, I suppose. You've got leaky brakes. You have a hard time stopping, so we better make sure you're pretty good on the road because otherwise you're going to get yourself in a lot of accidents. So we need to give you skills for how to manage the car, so to speak. But then there's other kids that come in that are more I just want to be normal. I want to be like everyone else. I don't like standing out. I want my stereo turned down. And so those are more of the kids where, something like Nix is important because that will actually be their how-to guide to say, okay, which tics don't you like? Which tics, do you really wish were gone? And boom, here's how you get rid of them. Or that might be where a medication is more relevant. An interesting thing about the medication literature is that, we often think, well, talking about, what's this person's definition of success, that's just fluff. Let's just give them the treatment. That's real. But, the interesting thing in the medication literature is that if a person doesn't want to take a medication, it's less effective than if you do want to take it. And so it's not, a person's mind frame or attitude is not just fluff. Like if a person likes their stereo loud and you're trying to turn it down, it's not going to work so well.
And it's just important because that's something that you discuss in the book, and it's so important that you get your kid. Because, what may seem to be the obvious choice is really something that could just make it worse for them.
Absolutely. And it's why I very purposely, and I've taken a bit of flack for, my writing style in the book. It's very, it's very aimed at kids. Like, I'm glad parents find it helpful and such, but I really wrote that book, I wrote it just acting as if I was talking to one of my, 10, 11, 12-year-old patients who don't like to read, that don't want any bullshit. They just want the straight goods. In that book, I really emphasized that, if you come up with a list of tics you hate that you don't want to work on, or that you want to work on, and your mom comes up with a completely different list, and your teacher comes up with a completely different list again, screw their list.
Right.
It's your list I care about. Because this Nix your tics isn't about telling you you'll be a better, more acceptable person if you don't have tics. It's about making your life as the individual with Tourette's the way you want it, to raise your quality of life so that you're happy.
And what I love about your website is that you have articles that are written about yourself as an adult and relationships, and I want everyone to know that because the apples don't fall far from the tree. And it's really, you have great articles in there, and you're very open about your life. And it's really something that adults are going to find very helpful, too. And I do have one more question. I had quite a few more, but I want to get this one in. Parents often ask, how do they know what the cause of a behavior is? Kids are kids. So, how does a parent know whether a behavior is from the Tourette's or from just bad behavior? And how do they instill accountability, whichever it is? Because I love the analogy that you give that about a blind person, that the blind person is not to blame for their lack of eyesight, but he is to blame if he knowingly gets behind the wheel and hurts somebody.
Right. No, that's a good question to end on. If you like that one, I'll throw another quote at you, but I can't take credit for this one. This one's Sir Winston Churchill, and he once
my favorite.
Said, well, he once said, "My right to swing my arm ends at the other person's nose." And
right?
that's kind of true no matter what you got. I mean, you can call it Tourette's, ADHD, OCD, ABC, XYZ, a hangover, or a hangnail. But, I mean, there's certain things you're allowed to do in this world, and there's certain things you aren't. And, ultimately, I guess I'll give you two answers to that question. First of all, I'll say that question is unanswerable because really what these disorders are, as I've said earlier, they're disorders of dysregulation. And so it's about your brakes not working very well over different aspects of yourself. And so it's not like there's you and then separate from you there's the Tourette's or separate from you there's the ADHD. It's all you. It's just that it's you with leaky brakes so that the normal things you're thinking or that pop to mind as impulses or normal reactions that anyone would have are a little bit bigger in you. The stereo's louder, as we said. It's in a sense, you don't have the privacy to keep certain things internal that other people do. And so asking is it the kid or the disorder is kind of like asking is that area of the rectangle due to its length or its width. Like it's just a nonsensical question. It's both all the time. But then the other answer I want to give then is that since that question doesn't make sense to ask, since there's no real answer to that question, ask a much more productive question that's going to lead to that accountability and that people are going to agree on a whole lot more, which is it acceptable behavior or not? Our galaxies exploding, our worlds colliding, and if so, we got to deal with it no matter where it's coming from. And if not, leave it alone. And again, it doesn't matter where it's coming from. If I remember correctly, you've interviewed Ross Green before, and
yes, several times. Yeah,
it's his approach of basket A, B, and C can really apply to this situation. That when Dr. Green's talking about does something need to go in basket B, or how the steps for going through basket B. None of those steps involve figuring out whether the kid's doing it on purpose or not. It's just about, we've got an issue, let's work it through. And that really, really applies in this situation too.
And, I think also what you said was very, very important, and I don't want to just gloss over it. You said that it's a part of them. And this is something I tell parents all the time, is to choose your words carefully. Because the way you talk about the disorder is really a reflection on the child.
Yes.
And it's just so important that you choose your words carefully because they can separate themselves from it. And I like the way you, one of the things you talk about in one of your articles is acceptance, which I'm big on acceptance.
Yeah.
And you talk about educating yourself on the neurology and psychology of Tourette's is the best way to understand and accept it.
Yeah.
Can you explain that?
Well, I think that you can't really accept something until you understand what it is and the parameters around it. That, you may think you've accepted your Tourette's, but then there's a whole other facet of your Tourette's, whole different symptom, or it comes out in a different place where you weren't expecting, and you're kind of back at square one to have to accept that again too, and accept the next thing, and so really you're going to be a lot less surprised, which of course is going to help with your symptoms too, because you're not going to be as stressed, you're not going to be living life in a minefield. By really getting to understand what's going on, so that you can explain it to yourself, you can explain it to others, and then people really know the boundaries around it. People really know, okay, this is what it is, this is what it isn't. All right, we're good. Let's get on with life.
Right, and it's such a frightening disorder. I know my daughter tells me that until she recently got the diagnosis, she thought she was just going crazy, and it made her feel better to understand the physical part of it, what was happening, the chemicals in her brain. It was just I think it's very calming to understand why what's happening is happening.
Even just something as simple as stress makes the tics worse. If you don't know that, which a lot of the kids who come in to see me don't, then they all they know is that when they least want to be doing tics, when they're really putting pressure on themselves to not tic, that's when they tic. And so without a proper explanation, they're often coming to my office saying, I think the devil's in my head. Like, I think someone really has it in for me, is reading my thoughts and is persecuting me from within and doing the exact last thing I want to do. And so you can actually, in terms of just like an inner life, torture yourself a lot more and feel a lot more paranoid, or a lot of unnecessary emotions simply through lack of knowledge.
Right. Well, Dr. McKinley, I really want to thank you for joining us. You're helping a lot of parents through your work, and you're going to help a lot of parents through this interview. Nix Your Tics, N-I-X, Your Tics. That can be purchased through your website, Life's a Twitch. Can they get that on Amazon or anywhere?
I don't sell it through Amazon yet, anyway, but if you go to my website, there's links to the distributor. They can either order it online, or they can download a mail-in form that they could fax in, or they can even phone the distributor. Or, on Facebook, I've got a Nix Your Tics book group, too. It's basically kind of an online extension of the book for people that just want to support each other in doing the treatment. And there's the links to the book from there, too.
You, like so many other of the great guests that I've had on, you are just, you interact so much with the people on Facebook and in your group, and I really encourage everybody to go over there. You just stop in, you talk to the parents, and it's such a great feeling for parents. You have no idea what that does for a parent that's so confused. And we didn't even get into your documentary, your award-winning documentary, Life's a Twitch. Where can people view that?
Well,
I know we can get the trailer off your website.
Well, and I should say that I didn't produce the documentary. I was merely the subject in it. Symmetry Media produced it, but I'm really happy because now the National Film Board is streaming it for free, and there's no geo-blocking. It's available anywhere in the world. And so again, if they go to my website under the documentary section, I've got the video embedded in my site, so they can just watch it straight from the site now.
Yeah, I watched it again. It's fantastic.
Life of Twitch documentary has come home to the Life of Twitch website.
Yeah, I mean, I watched it again. It's fantastic. So again, I thank you for joining us. Come back anytime. If there's anything that you find out that parents should know, please give me a call, and we'll have you on any time.
Well, I'm pleased to come back. Sounds like we always have lots to talk about.
No, we do. The people on the chat are saying we needed a few more hours.
I'll accommodate.
Okay, because the parents really do want to know more about, the way that you, the way you explained it in your book with the Nix Your Tics, the different treatments that you use, because it's really, and the thing I think is so important about it is that if you use these techniques with young children, they will have this tool the rest of their lives, because Tourette's, you don't outgrow it, right? Right. So I'd absolutely love to have you back. So thank you for joining us.
Oh, my pleasure.
You're welcome. As I end the show each day, you are your child's best advocate. If not you, then who? Become an informed, educated parent here at the Coffee Klatch. Thank you for joining.